Okay, good afternoon. This is the workshop on MR of ankle marrow. It's actually really nice. I see a lot of familiar people in the audience, people who I trained with, some people who I trained, and a lot of familiar faces from previous courses. We always want to make this interactive. It rarely is interactive as much as it should be. So even if I get through this slide only, it's okay. If we just discuss issues and talk about questions, that's fine. I have stuff prepared, but I don't have to stick to what I have prepared. And I have an awful lot prepared, and I can skip around to issues that might be important in your practice. So please interrupt me, and I'll try my best to try and make it interactive. And I'm sorry, I don't have my jacket on, but I get kind of sweaty and hot, and you don't want to be near me when that happens, so I have my jacket off. So I kind of gave you the introduction to general concepts of marrow edema, which I think is a really, really important concept. And just by way of an anecdote, I used to work in Philadelphia, and we had a really big hand surgery center. And they would never send anyone for an MR of the wrist because they wanted to scope everyone, and they wouldn't give up any scope because an MR may show something wasn't there, and they really wanted to scope everyone. So the only ones who they would send for MRs are things that they couldn't see at arthroscopy, which was marrow. And gradually, when we started doing marrow, which was Kienbach's and Prizes syndrome and what have you, they eventually saw that we were pretty good at the stuff outside of marrow. And it went full circle that marrow ended up being the hardest thing in the wrist, even though we had the most experience in it. And I think the wrist is actually easy compared to the ankle. So we're going to talk about the ankle. And here's something that's relatively straightforward. This is an Achilles tendon to bone anastomosis. And this is a normal anastomosis. And this is a normal variant in the anterior calcaneus of penetrating vessels, something I spoke about earlier. So we're going to talk about variance in the ankle. We're going to reiterate the definition because everything bears some reiteration for everyone. We're going to talk about the severity, again, to reiterate a little bit about what we talked about, but specific in the ankle. We're going to talk about some pearls that we use. Thank you, Sheila. Some pearls that we use that work for everywhere in the body, but particularly in the ankle. We're going to spend a little bit disproportionate time talking about traumatic causes of marrow edema, but not to the exclusion of avascular necrosis, non-union stress injury. We're also going to talk about osteochondral defects and their mimickers, things that are associated with marrow edema, so-called reactive edema that I spoke about. And lastly, disorders of marrow that are an edematous. And I don't know how to quite phrase this because it's marrow edema, but there's something wrong with the marrow, but it's not edema. So here is an example of a lesion in the talar dome, and there's a rim of high signal around it. Anyone have an idea what this is? Osteonecrosis, excellent. And you can see that there's collapse here, right? So collapse is impaction injuries like a plateau fracture, dislocations, and osteonecrosis, right? If you image dislocations of the ankle, it's for osteonecrosis, so forget that. You don't get impaction injuries or fractures, you get fractures of the tail and neck. So once you see the marrow edema and the impaction, there can't be any differential diagnosis. It has to be osteonecrosis, and the fact that we see the double line sign even makes it more straightforward. So I always like to begin with variance. We'll talk about the variance of the ankle specifically. One is the anterior calcaneus, and I showed you that in my first slide. That is that area of marrow edema, almost little rounded lobules of marrow edema right by Gassan's angle where the subtalar joint ends, and we've all seen that on images. And that's normal. It's vessels going through the reversion canals, and it's asymptomatic. The second thing is when looking at the Lisfranc joint and the midfoot, never call something that you see on sagittals only. The way those bones interdigitate is too complex. And you can volume average fluid in the bones, and you can think there's edema there when there's not. So normally, if you see edema in one plane, it's good enough. But the cuneiforms are a notable exception to that. Never read them on sagittal images only. We're going to talk about ostrigonum syndrome in a lot of detail. But every edema in the ostrigonum is not ostrigonum syndrome, or at least is not symptomatic. It has to be pretty florid edema for it to be symptomatic. And we're going to show you examples of that. When you do frequency selective fat suppression, the phalanges can be bright. And when you're looking at osteo of the toes, this can be a big problem. And I've had it a big problem. So you always want to do one non-fat suppressed image in that plane and make sure that marrow is in fact low on that non-fat suppressed image, because the phalanges in these osteo patients are a specific problem. And I spoke about this turnover and I showed you an example of that in adolescence, and we particularly see this in the ankle, but also red marrow in this very young child. We see all red marrow here in a calcaneus and talus. This is the zone of, this is the ossifying physis around it, but this is just red marrow. And that's easy to know it's red marrow. Maybe if it was a leukemic patient, you might have a question, but in general, it's pretty easy. I think it's the high turnover in adolescence where you might have some other more difficult causes of marrow edema that creates a problem. So we said marrow edema is leakage of fluid, and we're going to talk a lot a bit about morphology in the ankle to tell what it is. And again, I'm a firm believer in always having a T1 weighted image to evaluate for marrow. You can see normal marrow in the third metatarsal, and in the fifth, there is marrow edema in the fourth. There is also cortical thickening of the fourth. There is only one thing that can cause cortical thickening in marrow edema. If you had cortical thickening alone, it could be venostasis. It could be an old fracture. It could be a healed infection. Marrow edema could be infection, could be a stress fracture, could be an acute fracture. But if you have cortical thickening and marrow edema, if we put those two Venn diagrams together, the only thing left is a stress fracture. So you need a T1 weighted image, and you need to look at morphology. So there's only one thing that will give you marrow edema and cortical thickening. Kissing changes, as I spoke about, is articular disease. Articular disease in the hindfoot is always the subtalar joint, 98% of the time. So if you see articular disease in the middle facet, that has to be a coalition, because you don't get articular disease there. So you can look for the coalition, and they're really hard to see on MR images. Or you can infer that one is present, as in this case, and it is present. So we talked about always getting T1 weighted images. This is going to be review before getting to the details of the ankle, to grade the severity and to look for specific disorders that are more overt on T1, most notably AVN and metastatic disease. You'll want to look at the soft tissues adjacent to it. And in the end, we're going to go by location and use a pattern approach. So we're going to go through every bone. We're going to talk about the 3 or 4 things that occur in every bone. Then we're going to do locations. Then we're going to do patterns. And once you know the 3 or 4 things in every bone and you know the potential patterns, you can have one diagnosis. There may be a differential, but usually it's one diagnosis. So here we see something on a T1. Sorry, this is a PD. And on T2, we see a crescent. So again, a crescent, insufficiency fractures, right? Cartilage defects, and avascular necrosis, right? This is extending too far anterior to be a cartilage defect. Insufficiency fractures of the talus occur more distally, not at the talar head. So the crescent is the pattern that gives you the differential. The location tells you that it has to be avascular necrosis. Not only that, but it has to be acute avascular necrosis, because we see the marrow oozing out. This is joint fluid, but the joint doesn't come down to here. This is soft tissue reaction around it, soft tissue reaction into the sinus tarsi. So that tells you that it's something acute that's oozing through. So now we know not only is it AVN, but it is an acute AVN, and therefore potentially reversible. So very specific diagnosis. This is a low field scatter, not the most elegant images by any means, but very, very specific. Okay, so we reviewed the definition. We reviewed some background information that we talked about earlier this afternoon. Now let's go into detail about the ankle. And please make this interactive. If I don't see you raising your hands, jump up and down, or throw a paper airplane at me, do something. So again, in the foot and ankle, we don't care about metastatic disease. Almost unheard of. So if you see it on T1 more than T2, it's avascular necrosis. And I should throw in osteomyelitis here. AVN or osteomyelitis. Occult fractures in the ankle only, do not need to have a fracture line. This is very, very important. If you see something that you're fairly sure is not a bone bruise, and we'll talk about how you can be sure, it doesn't matter if you don't see a fracture line. It is an occult fracture. It will behave like an occult fracture. Well, how do I know it's not a bone bruise? In the ankle, 99.9% of bone bruises are seen following ankle sprains. 90% of ankle sprains that you image involve the lateral ligaments. 90% of those lateral ligaments involve the anterior talofibular ligament. Therefore, if the anterior talofibular ligament is normal and I see something, chances are it's an occult fracture and not a bone bruise. Okay, so go out of your way to call something an occult fracture, not a bone bruise. If you see this edema that's traumatic in the cuboid or the cuneiforms, always evaluate the Lisfranc ligament. Really tragic to miss the Lisfranc ligament. And about 30% of people with cuboid or cuneiform bruises or fractures are from a Lisfranc injury. So most cases won't be a Lisfranc injury, but a third of them will be. And most of the time, unless you look carefully, you're going to miss it. Weird, again, my wife doesn't like when I put these in, osteoarthritis is pretty common in the ankle and the foot. And so don't almost never discount a potential diagnosis of osteoarthritis because you think it looks atypical for osteoarthritis. If it's very disproportionate on one side of the joint, if it's dissecting very far from a joint, that is still more likely osteoarthritis. And since one of my old co-residents is in the audience, I'll quote my ex-chairman, Jerry Irwin, who used to say, if you're under a tree and a zebra falls on your head, it's more likely to be a dysplastic apple than it is a zebra. So his point, which is a great one, is that uncommon manifestations of common disease are far more common than uncommon disease. So in the ankle, you're going to see osteoarthritis, osteoarthritis, and osteoarthritis. And weird manifestations of osteoarthritis are going to be much more common than psoriatic arthritis. A clinician called me the other day with a report that someone from the outside read as being some peculiar arthropathy. And on the basis of the imaging, it was a peculiar arthropathy. And I said to him, yeah, it could be a peculiar arthropathy, but I bet you it's just osteoarthritis. What do the patient's hands look like? And he goes, the hands are completely normal. The rheumatoid factor is normal. In fact, it was just weird osteoarthritis. It wasn't rheumatoid arthritis, even though you could think it was rheumatoid arthritis. We talked about this associative or reactive edema. And it's really, really common in the foot, particularly at the PTTs, the perineals, the sinus tarsi, the plantar fascia, and with Haglund syndrome. And when you see that, it's real good because you know that that tendon or that soft tissue adjacent to it has got to be abnormal. And you know that that's the symptom generator because not 100% of the time, but pretty damn close to it, the edema is the symptom generator. So here is a patient. Do we want to evaluate this cuneiform here? No, we don't, right? You never evaluate cuneiforms on sagittal images only, right? But we can evaluate the navicular on sagittal images only. So I see something that's relatively subtle on T1, right? Yes? But pretty obvious on STIR. So according to the severity rule, this is not that severe, right? But according to the bone bruises don't occur in the ankle outside the setting of ankle sprains, this can't be a bone bruise. So this is an occult fracture of the navicular. Okay, doesn't matter if you see a fracture line or not, and doesn't even matter what the T1 weighted image shows, because if you don't call this an occult fracture, they're going to go on to non-union and AVN, or at least they have a reasonable possibility of that, right? Basically, you don't see bone bruises outside of ankle sprains in the ankle. Now, we know that this is then an ankle sprain, because we see a bone bruise medially and a bone bruise laterally, and they're relatively kissing, right? The thing that's a little bit weird about this case is usually the impaction bone bruises are bigger than the distraction bone bruises. So one might question whether this was a medial ligament injury, and in fact it is, because we saw the soft tissue edema dissecting up here. So the impaction side is greater than the distraction side. And this is a bone bruise in the setting of an ankle sprain. Does it matter what the T1 weighted images look like? No, unless you see a fracture line. because bone bruises with ankle sprains, if not invariable, are much more than 50%. Okay, so those are pearls. Then we're going to do location, and then we're going to spend about 30, 40 minutes talking about patterns. And at the end of this, you put the pearls together, you put the location together, you put the pattern together. You should have one diagnosis 95% of the time. Not 100%, but 95% of the time. So let's do locations. In the tibia, only two things that occur there with any degree of frequency: bone bruises from ankle sprains and reactive edema from PTT tears. Yeah, occasionally a stress fracture, occasionally a cold fracture, but most of the time, over 90% of the time, it's one of these two things. In the talar dome, limited differential, osteochondral defect, or subchondral cyst. All these slides, every one of them is on the CD, and then some. If it's in the talus, whether it be medial or lateral, it's a bone bruise, medial PTT tears, lateral perineal tears, or arthritis. A key concept about arthritis is when you see marrow from arthritis, it's often at the very edge of a joint. If you see this on knee MRs all the time, the marrow from the arthritis, early arthritis, is at the very, very edge of the joint. Same thing in the talar dome. If you see arthritis, it's at the very edge, which is why it can mimic an OCD, because OCDs are at the medial and lateral edges of the talus. If it's in the body and neck of the talus, it's either AVN, an occult fracture, or if subtle, reactive edema and a sinus tarsi. If it's in the talar head, it's an uncommon but not rare location for a bone bruise, or cartilage loss from the talonavicular joint. Again, so you see each of these has no more than 3 differential diagnoses. So here we have it in the body and neck of the talus, right? And we see it on a T1 weighted image, right? So there is no differential, it is. If I go back, body and neck, AVN, fracture, or sinus tarsi. So which is this, AVN, fracture, or sinus tarsi? Well, not subtle, right? So it can't be sinus tarsi. It's either AVN or a fracture, and it happens to be AVN, but you limited your diagnosis. Continuing with locations, going more distally. If it's the lateral aspect of the calcaneus, it's bone bruise, POPS syndrome, and we'll talk about that in a second. Or if it's medial, it's PTT. Who's heard of POPS syndrome? It's kind of in vogue. I've heard of it. It's in vogue in the foot and ankle literature. It stands for painful os peroneum syndrome. And what it really means is the patient has pain in the region of the os peroneum. It's not necessarily true that the os peroneum is the symptom generator. It's actually often the distal perineals. And patients who present clinically with POPS almost always have edema in a lateral calcaneus by the perineal tendons. It's very, very specific. I'll show you examples of it. If it's the calcaneus by the sinus, it's sinus tarsi syndrome, osteoarthritis, or fracture. That's the typical location for the major fracture. If it's in the navicular, it's osteoarthritis, avascular necrosis, reactive to PTT tears, a fracture, or an accessory ossicle. We got a problem here, though, right? I usually said there's 3 choices. There's 5 choices here. Okay, that's a bit of a problem, so we're going to spend a good 6 or 7 minutes talking about that. In the cuboid, 2 traumatic disorders, bone bruises and occult fractures. Either of these you should think of. Good, Liz Frank injury. And osteoarthritis. Cuneiforms, osteoarthritis, and again, rule out Liz Frank injury. A little bit about the metatarsals. When you have articular edema in the metatarsals, it tends to spread all the way distally and can even go up past the halfway point of a metatarsal. And I can show you an image through the metatarsals right in the midpoint. And marrow, metatarsal looks like a circle. And I can tell you that's a stress fracture, and I'm lying. That it's articular disease dissecting up. And you see this all the time, particularly in diabetics which show co-arthropathy. It's not a fracture in them. It's just the articular disease. In osteoarthritis, for some reason, the metatarsals, the edema, dissects all the way up distally. Okay, so this is what I was talking about with POPS syndrome. You can see the abnormal signal within the peroneus longus here. We see the perineal tubercle here, and on the sagittal stir, you see the edema right as the perineal tendon goes around that perineal tubercle. Can you see that? And they call this POPS syndrome, but most of the time it's not from the os peroneum. It stands for painful os peroneum, but basically they have edema in this region. And most of the time, I would say 70% of the time, it looks like this. It just has edema somewhere where the peroneus longus and brevis, about where they're going to split. Okay, so we gave you introduction, we gave you pearls, and we gave you locations. And every location had 3 choices, except for the navicular, which had 5, and I think one other one had 4, right? So you should limit your diagnosis without even looking at the film. Your partner calls you up and says, I have edema in a lateral calcaneus. You got 3 choices for that edema in a lateral calcaneus. And now we're going to talk about patterns and how each of these potential things looks on imaging. So we're going to start with traumatic injuries, and we got 3 traumatic injuries that are a spectrum of severity. Bone bruises, occult fractures, and true fractures. The definition of an occult fracture, again, if your partner ever brings this up, is it's not seen on the initial reading of the initial x-ray. If he says, hey, bud, I can see this fracture that you missed. You didn't miss it. It's an occult fracture. Hindsight is 20/20. So any fracture that's not seen on the initial sitting is an occult fracture. That is the legal definition in the orthopedic literature. If we image true fractures, we know they have a fracture. So we're looking at fracture complications. We're going to spend a little bit of time looking at that. So here we have marrow edema in the medial tibia, right? What's a differential diagnosis? Anyone? It's supposed to be interactive. It's a workshop. I can hear people. I'm sorry if I can't hear what you're saying. PTT, reactive edema, and bone bruise from lateral ankle sprain, right? Only 2 things that can do this because it's away from the joint. Okay, we're going to look at our lateral ligament, and we can see soft tissue edema dissecting up here. So we know this is a lateral ankle sprain, and we know the medial bone bruise is going to be bigger because that's the impaction injury. The tensile, the ipsilateral side, is going to be more subtle, so we know this is an ankle sprain. Bone bruises are painful. They're most common in the knee, where I go out of my way to overcall them. They're somewhat unusual in the ankle, except in sprains. So unless there's an ankle sprain, I go out of my way to undercall them. There are 3 patterns. We won't talk about rotational because of time, but the compressive should be bigger and more obvious than a tensile. And the compressive are usually going to be medial because most ankle sprains that you image are lateral ankle sprains. They resolve without sequelae. They only need treatment to ameliorate their symptoms. The treatment should do almost nothing for the natural history. The longer they take to resolve, the poorer the patient protoplasm. You know, they smoke, they have diabetes, they're elderly, they have osteoporosis, they have something. But they should resolve in everyone in 12 weeks. Now, they may not resolve on imaging in 12 weeks, but their symptoms should go away in 12 weeks. So here we have another example. We have a medial tibia, medial talus, and medial calcaneus. And on a different patient, lateral talus and lateral calcaneus. This is the impaction. This is the avulsion. And you can commonly see them in a talar neck. And a talar neck presents difficulties because there's 2 really big, horrible diseases that are in your differential, AVN and talar neck fractures. So with these, always look at your T1 and make sure you don't see it on T1. And number 2, always look at that lateral ligament. So if that lateral ligament, yes, Susan. It should also go away in 12 weeks, but I've seen them up to 20 weeks, and I still think that they're healing bone bruises. Anything else? Okay. So this is the one I think that is more worrisome, that you have a differential diagnosis for. But remember, look on your T1. That's why for Marrow, I think you always need to do a T1 weighted sequence. Well, to see an occult fracture, it should be abnormal in both T1 and STIR to be an occult fracture. And again, to reiterate, you don't have to see a fracture line. And I think they behave the same whether they have a fracture line or not. So here's a child following an ankle sprain. And if we look on a T1 sagittal, you may argue how subtle this is, but there is no doubt that you can see this. And this person, you happen to see the fracture line on STIR. And even though this is an ankle sprain, in quotes, this is a distal fibular fracture. Not really important because it's treated basically without any treatment. Okay, here we have a patient. We have something in the anterior calcaneus, and we see it on a T1 weighted image. So what are your thoughts? Has to be an occult fracture. Not necessarily because you see it on a T1 weighted image, but because this is not where you see bone bruises from ankle sprains. It's not at the compressive side, which would be all the medialmost aspect, nor is it on the tensile side. It's in the middle of your foot. And this is the most common occult fracture you see in ankle sprains. And this patient may present a problem because you may see an abnormal ligament. In fact, you often will. But it still is an occult fracture. So has to be an ankle sprain. It has to be in a typical location for an ankle sprain. Yeah.
With these occult fractures, do you will then go to CT or
No.
something to document them, or you just?
I don't think so. Because I would say a CT would hurt you because you may not see the fracture line, even with a good CT. I'm really, I've done a lot of follow-up radiography on these. You get sclerosis, you get periosteal reaction, they're occult fractures. And what's the harm? They go into an air cast for 6 weeks? We don't do CT. In fact, I can't. A few professional athletes we did, but besides that, no. Okay, other questions? Because give me a chance to drink, so please ask questions. Okay, so here we have a STIR and a T1 weighted image, right? Doesn't matter what the T1 weighted image looks like, not where you see a bone bruise. And we see a fracture line. So what should you look at next? Lisfranc ligament. Okay. In a known fracture, you image them for complications. And the major ones that we image are for malunions, osteoarthritis, and tendon disorders. So this was a pretty obvious joint depression calcaneal fracture, right? Here's a fracture line. Here's a displaced fragment. And this is a malunion. And the risk would be FHL entrapment. But we can see the fracture line goes posterior to the FHL. So malunion, can wear shoes, but no tendon problem. Another calcaneal fracture, joint depression fracture, right? Displacement of this fragment out. And what's the secondary finding here now? Osteoarthritis, right? So they're going to autofuse their joint, which is not a good thing, but not as bad as it could be. Another calcaneal fracture, this is the CT, and here's the MR. We didn't CT this because this is an occult fracture. It started out with the CT, and we saw the dislocated peroneal tendons. So 3 complications of calcaneal fractures, any occult fracture that we tend to image. Malunion, particularly the risk of OA, tendon disorders, and we don't image that much for non-union a little bit. Okay, next thing, avascular necrosis. So we talked about trauma and the spectrum of severity from bone bruise to occult fracture to true fracture. And now we're going to talk about avascular necrosis. AVN distal to the knee is basically never from systemic disease unless they have lupus or sickle cell. So basically all AVN that you're going to see in the ankle in real life outside of universities is going to be from focal disease, and I include diabetic pedal disease as focal disease. So diabetic pedal disease, spontaneous, and post-traumatic are most of the causes of AVN of the foot and ankle. Obviously, we do a lot of systemic disease. What do you think of these cuneiforms here? I think several people said you can't evaluate them, right? Because you never evaluate the cuneiforms on sagittal images only, right? That was a little trick question. But the talus is what is abnormal here. And we have an abnormal line at the talar head, an abnormal line at the talar dome. And you can see the collapse of the talar articular surface, and we can see the double line sign, which, to reiterate, is a dark serpentine rim on a T1 weighted image, the inner aspect of which becomes bright on a T2 weighted image. Okay, so we know that this is AVN.
What produces the findings on the cuneiform of the Sagittarius?
It's volume averaging because they interdigitate, and you're not getting between them, so you're seeing a little bit of fluid between them. I've been burned, and I've made so many mistakes looking at the cuneiforms, calling things that on follow-up, because they oblique them slightly differently, look completely normal, that if I don't absolutely confirm it on a different plane, I don't even mention it. They're so rare, and it's so easy to overcall. This is a case I showed you earlier. Freiberg's another example of AVN. Post-traumatic AVN we talked about in the foot. We mentioned the fifth metatarsal base. In the ankle, it's going to be in the talus and in the navicular. Interestingly, the calcaneus following trauma has so many complications, right? But AVN is not one of them. It's got a great blood supply. So AVN in the ankle, two bones, talus and navicular. Now this would be a more subtle example, right? Because you have an articular crescent, right? What is our differential for a crescent again? Osteoarthritis, insufficiency fracture, and osteonecrosis, right? This could be osteoarthritis, right? But it's not quite at the edge, and we see nothing kissing on the other side. Insufficiency fractures of the talus always occur at the talus neck. Can't be an insufficiency fracture. So it has to be avascular necrosis. Base of the fifth metatarsal. It's interesting. If you saw this T1 weighted image only, I think you would call this normal, right? It's only when you look at the T2 weighted image that you see that this is a whole fragment here that is edematous. I kind of like the case because it's a little bit of an eye test. If you look at this here, you can't even see that. And this is a Jones fracture with avascular necrosis. Anyone know who Jones was? He was an orthopedic surgeon, and he actually described his own fracture. Scotland, you guys know more than I do. Yeah. And AVN of the navicular. Now, the navicular creates problems because it gets these insufficiency fractures. It gets peculiar OA because it's got this really high trabecular ratio, and you may see edema there only and not necessarily in the talus, and gets AVN. And I'm not even sure that they're different diseases. I think just like in the knee, where we used to call things SONC, and now we think most are insufficiency fractures, I got a sneaky feeling that these things that we call AVN and navicular are also going to end up being insufficiency fractures. So when I would see this, in almost all cases, I would give a differential diagnosis of AVN versus insufficiency fractures, kind of the same elderly group of patients. And it's not a big deal because the treatment's going to be the same. They're going to do limited weight bearing on them, and they're going to follow them up radiographically. So, you know, although I call this AVN and it's in my AVN section, I'm not 100% convinced that AVN and insufficiency fractures are really that different, and for that matter in the talus as well, but in the navicular. Acute AVN, we talked about a little bit earlier, gives you ill-defined edema. You don't see the double line sign. You see a soft tissue reaction around it, and it should provoke a joint effusion. And it's in these things that cause acute pain. So old AVN causes kind of dull, joint-like pain. Acute AVN causes fairly intense, debilitating pain. The patient's going to be limping. They're going to be on crutches. It's a really different kind of history. And this is another one. I showed you one of the talus earlier. This is another one of the talus. You see this diffuse edema in the talus. You see it oozing out into the soft tissues. You see it provoking a subtalar joint effusion, oozing out into the sinus tarsi. And could you call this an insufficiency fracture? Yes. Would you be wrong in calling it an insufficiency fracture? I'm not sure you would be. I think it's like the navicular, where they may end up being the same thing. But this is purportedly the prototype for AVN. The double line sign is less common in the ankle. We showed you what it was. It's a dark signal rim, the inner aspect of which becomes bright on a fluid-weighted image. It tells you that it's AVN, it's old, and very interesting, it's from a systemic disease. So if you see this in the ankle, you can be a show-off when you go to the clinician. Does this patient have lupus, diabetes, or sickle cell anemia? Because really those are the only three choices in the ankle. None of us are going to be show-offs. And this is a case I showed you earlier of sickle cell disease. Infarcts in the calcaneus are pretty characteristic for sickle cell disease. Another thing that you would image a fracture for as we said, AVN in the ankle is usually not going to be from systemic disease. It's going to be from a fracture, spontaneous or spontaneous. The other thing that you might image a fracture for is for a non-union or a pseudoarthrosis. And in the ankle, we see that in the distal fibula and in the navicular and rarely in the talus. You never see this in the calcaneus. You rarely see it in the metatarsals. You'll never see them in the phalanges. And when you image a non-union, most of the time the clinician knows it's a non-union. You're imaging to look for a pseudoarthrosis, which is fluid at the non-union. And this is a case I like to show. This was a fracture that was, I think, 6 or 9 months old, and it's a fibular fracture. And we can see that there's edema on both sides of the fracture line, but the fracture line itself is not fluid. Can you see that? So this is a non-union, but not a pseudoarthrosis. Anyone guess the gender of the patient? Female. Most suprasyndesmotic fibular fractures occur in females. Gynecoid pelvis, more weight-bearing laterally. If you're going to see a non-union in the ankle, it's going to be 80–90% of the time navicular, occasionally talus and fifth metatarsal. So here's an example of one. This is, you see the line in the navicular. This is an axial fluid-weighted image. This is talar head. This is lateral navicular, medial navicular. I'm sorry, medial navicular, lateral navicular. This is sustentaculum tali. So can you see the line through the navicular? Navicular fractures are always sagittally oriented. Very easy. Just like sesamoid fractures are always coronally oriented, navicular fractures are always sagittally oriented. So you know that this had to be a fracture. And this, in contradistinction to the fibula, where we see a low signal line on T2, we see fluid in this. So this is therefore a pseudoarthrosis. Right? Okay. Related to a non-union is what happens to accessory ossicles. And this is the same thing that happens to a bipartite sesamoid, the same thing that happens to an ostragonum, the same thing that happens to a bipartite patellae. The concepts are the same. Okay? When you have an accessory ossicle, there is a fibrous synchondrosis with the native bone. Synchondrosis should have cartilage-like signal. Over time, you get micromotion on that. And initially, you get edema on either side. Then you get fluid with edema, and then eventually fluid without edema. And some people call it a stress injury because it is an overuse injury. I don't like to call it that, but it's not wrong to call it that. And that's, we're going to use the navicular as a prototype for that. So here is an axial T2 weighted image, calcaneus, navicular, accessory navicular. What is this, by the way? Very good. Normal variant penetrating vessels. So here is the accessory navicular and a native navicular. This should be a fibrous synchondrosis. Can you see the fluid in there? And can you see the edema on both sides of it? It looks just like a non-union, which is why I put it in the non-union portion of the lecture. And it's breakdown of that synchondrosis with formation of a pseudoarthrosis. How about this patient? Another accessory navicular, another native navicular. The synchondrosis remains low signal, but there's edema mostly on the navicular side, a little lesser degree on the accessory navicular side. And this is an earlier stage of that same breakdown of that synchondrosis. We'll talk about ostragonum syndrome, I think, in about 3 minutes. Pop syndrome is another accessory ossicle. This one does not have a synchondrosis. But as I said earlier in this workshop, most people with POPS syndrome, or who come in with the prescription that says POPS syndrome, don't have an abnormality of the ospironium. They have an abnormality of the more distal perineal tendons, plus or minus a Marrow abnormality in the calcaneus. Okay, this is an in vogue diagnosis among foot and ankle surgeons. And this is the case I showed you earlier, I believe, with this Marrow edema in the perineal tubercle that we see here in the sagittal images. And that's And they all look the same. I really should have had a different example, but I've seen probably 30 or 40 cases, and they all basically look the same, varying degrees of severity of edema right in that location. So if you see it in that location, it's a POP syndrome. I said 3 minutes, but 2 minutes. Ostrigonum syndrome. Same principle as accessory navicular. There's a fibrous synchondrosis between the ostrigonum and the native talus, just like there's a fibrous synchondrosis between the accessory navicular and the native navicular. So you can get the same spectrum of abnormalities with first edema on both sides of it, then fluid and edema, and eventually just fluid. There's always a however. So the however here is other people can clinically present with ostrigonum syndrome who have other abnormalities in this region. And kind of this reiterates the concept of what the requisition says only matches anatomically what we see, not diagnostically what we see. So when someone comes in with POP syndrome, you're going to look anatomically in the region of the os peroneum, but it doesn't mean it's the os peroneum. And in fact, most people who present with symptomatic accessory naviculars come in as query distal PTT. They don't even come in as accessory navicular. So the clinician gets the anatomic location, but often mistakes the precise bone or structure in that anatomic location. And that's the same thing in the ostrigonum. So someone may come in ostrigonum syndrome, and you're looking for the pseudoarthrosis. You may be missing two other findings that clinically cause ostrigonum syndrome. One of them is an accessory articulation with the calcaneus. Some fairly knowledgeable gentleman in a break asked me if you have a Shepherd's fracture, which is a fracture of the trigonal process, is that intra-articular or extra-articular? And the answer is yes, because if you have an accessory articulation, then it's an intra-articular fracture. If you don't, then it's not. We're going to show you examples of that. And when you have that trigonal fracture, it's called a Shepherd's fracture. Oh yeah, I'm sorry. One more thing. So when you have a ostrigonum that has some micro motion, the FHL runs in tight proximity to the ostrigonum. You've probably noticed this in axial images. It can mechanically obstruct that FHL tendon sheath, and you get a mechanical stenosing tenosynovitis, and that is key. And I'll show you examples of that, and I'll show you how it can be really, really misleading. So this is a normal ostrigonum. So here is the ostrigonum. Here's the native talus. There is low signal here, and we can see there is no fluid or edema here. This is physiologic ankle joint fluid. Okay, can you see that? I said before that you look for edema at the first stage at either side of the ostrigonum. And I used to call these all the time. You know, if you look on ankle MRIs, about 15% of them have some subtle edema in here. And some of my clinicians who really like me, pull me aside and goes, Mark, basically you're full of crap. This many people don't have ostrigonum syndrome. And I said, no, if they don't have it clinically, then I'm doing something wrong. So I went back and tried to see which the ones I overcalled, and they had edema like this, which is relatively subtle edema, at least in my mind. No effusion, really, physiologic fluid. So what do you do when you have something like this? You can be cautious, and I would suggest you do that, saying this is either at the high end of a normal variant or minimal ostrigonum syndrome. But this case was completely asymptomatic in this region. So accessory naviculae, I think whenever they have edema, are really symptomatic. I think ostrigonums, when they look like that, often don't have symptoms. They got to look like this to have symptoms. So you see the difference? Pretty subtle edema. Pretty obvious edema. Let's go back. Subtle edema, still black synchondrosis. More obvious edema, still black synchondrosis. These are the ones that are more symptomatic. And again, the overtness of this edema, use your T1 weighted image. Clear as day, there's complete marrow replacement on a T1 weighted image. Now this is an ostrigonum that has an extra facet that articulates with the calcaneus. Can you see how this is articulating with the calcaneus? Normally, the ostrigonum is rounded inferiorly and doesn't articulate with the calcaneus. Again, doesn't articulate with the calcaneus. Can you see that? So this one does articulate with the calcaneus. So if this was fractured, yes, it would be intra-articular. So this is slam dunk normal. This is probably a normal variant. This is going to be symptomatic. And what's the next stage going to be?
5 minutes.
Fluid in the synchondrosis, right? So here we see fluid in the synchondrosis, right? Displacement now, fluid in the synchondrosis, and the os is displaced out. And here's when it blocks the FHL tendon sheath. And you see this fluid collection back here? And you can follow this on images, and it's actually the FHL tendon sheath. You see how the osteogonum is abnormal? There's kissing edema there. And this fluid can be obstructed and not have normal flow and get very grungy and irregular looking. And I've seen not one, not two, not three, more than a dozen of these that mimic the soft tissue sarcoma. And they take them out, and it's proliferative synovitis. So when you have a mobile osteogonum, the FHL tendon sheath is in close proximity, and it could obstruct this and stop the normal flow of that tendon sheath. And then that normal flow gets very, very hypertrophic synovium because of hemorrhage and lack of resorption, and can look like a tumor. We're going to finish with stress injuries. To have a stress injury, the activity has to be new, has to be repetitive, and has to be vigorous. And here's a typical stress fracture of the calcaneus. We divide stress injuries as a continuum, just like we divide traumatic injuries as a continuum from bone bruise to a cold fracture to tooth fracture. We divide stress injuries into altered mechanics, which should be asymptomatic and completely reversible, to stress response, which should be symptomatic and completely reversible, to stress fracture, which is not reversible unless there is some intervention. So this is the case I showed you earlier. It's my favorite case because it's the first one, because I misdiagnosed this. I call these multiple bone bruises. That this is altered mechanics. Had a knee brace on. Took the knee brace off, started ambulating. Rapid bone turnover. No symptoms from the marrow edema. I believe he had some tendon disorder. Has marrow edema, and it completely goes away once they adapt to it. So altered mechanics, patchy edema, not seen on T1, reversible, no symptoms. Stress response, multifocal, see it on T1, always causes symptoms. Stress fracture, fracture line, periosteal reaction, and needs some intervention.